Okay, perfect. So, I would love, I'm really, really thankful for Dr. Gill coming and presenting on the Mom's Trial today for our May 2026 Journal Club. So I'll hand it over to Dr. Gill. Thank you so much.
Great. Thanks, everyone. Great to be here. I'm just going to put this in full screen. Does that look okay?
Yes.
Okay, great. Well, really excited to talk with you all about this study today. We were so happy to see this finally in publication and hope we can have some good discussion about it too. I'm happy to just run through the results and then feel free to put some questions in the chat if that is your preference. We might have a little bit of time at the end to address some questions as well. But this was what we refer to as the NIDA CTN Clinical Trials Network MOM study. It was medication treatment for opioid-dependent expected mothers, a pragmatic randomized controlled trial, essentially comparing preparation of buprenorphine extended release versus sublingual during pregnancy and the 12 months postpartum. And this was funded by the HEALIN initiative, but went through the NIDA CTN. So really the study rationale behind this was, as we know, taking an oral medication as opposed to an extended release medication like an injection. There's some limitations to having to take a daily med, just the daily dosing burden, the adherence, diversion, misuse risk. But really for pregnancy, I think what's specific about this drug is related to the peaks and troughs that we have in medications over the course of a pregnancy, just in terms of how drugs are metabolized, how we have different binding proteins, how the vascular volume is increasing, how we eliminate drugs. That level of drug is going to decrease over time. And so there was some thought that around using some of the weekly injectables, you could sort of plateau out those peaks and troughs and have a more stable dose. And so that was really sort of the rationale behind using this medication in pregnancy. Also, there hasn't been a randomized controlled trial in pregnancy with this medication, so it made sense to examine this in an RCT, and also looking obviously at effectiveness, but maternal and infant safety outcomes. And the study was conducted throughout pregnancy and the postpartum year. And we'll talk more about that. The primary aim, so the first thing that we were trying to demonstrate was just compare the illicit opioid abstinence during pregnancy between extended release and sublingual. Secondary aim was to compare postpartum illicit opioid abstinence and neonatal withdrawal syndrome between the two groups and evaluate the safety for maternal and infant adverse events. Sorry. So the hypotheses was essentially, as I sort of talked about the rationale, that the extended release would be non-inferior and potentially superior for illicit opioid abstinence. Just getting rid of those peaks and troughs, we might just have fewer cravings, fewer withdrawal, and therefore less likely to use. We thought maybe the extended release would improve neonatal outcomes related to as well, just because of that sort of stable dosing. And that the safety outcomes would be comparable between groups. So really no difference there. If you're not familiar with the Clinical Trials Network, there's about 18 or 19 nodes across the country. So they're funded by NIDA, really to be able to implement quickly pragmatic randomized controlled trials. It's often around medications or interventions that we know are potentially efficacious for the treatment of substance use disorders, but we want to kind of get them in practice quickly. So these pragmatic RCTs provide an infrastructure to do that. For this particular study, there were 8 nodes and a total of 13 clinics. And so you can see sort of the relative geographic distribution for this. It was really across the country. The Ohio Valley node, so John Winhuse's group was the lead site. He was the lead PI for the study, which was really a huge undertaking and just such a testament to what they were able to do. So I wish John were here presenting this because this has really been his work and it's quite a labor of love and a lot of work. So inclusion, who ended up in the study, you had to be age 18 to 41 years old. You had to have a singleton pregnancy. You could be anywhere between 6 and 30 weeks gestation. You had to meet DSM-5 criteria for moderate severe OUD, and you had to be eligible or actually already receiving buprenorphine treatment. You were excluded if you were taking methadone or naltrexone. You were medically or psychiatrically unstable. You had severe alcohol or sedative dependence that would require detox, or you were involved in the criminal justice system that would actually interfere with participation in the study, which is literally weekly visits. These individuals came in every single week through pregnancy and every single week through the postpartum year. This is just our consort diagram to give you a sense of how we sort of brought people into the study and who was not in the study. So about 244 people were actually pre-screened. A lot of those people where they sort of fell out is that they never showed up for that initial screening visit, or they scheduled the visit or didn't attend, so didn't sort of get past pre-screening. The people that came in then got screened. There were folks that didn't actually come in and complete that screening, but just a handful of them were not actually eligible once they got to the screening visit. You can see those reasons there. This is our rest of our consort diagram. In the end of the day, there were 140 participants that were randomized. There were 69 that got assigned to extended release, 71 that got to sublingual buprenorphine. And then you can see just in terms of people completing the pregnancy phase and then completing the study through 12 months postpartum, pretty decent retention of participants if you think about this population. But in the end of the day, it was sort of an intent to treat design. So if you got assigned to extended release or sublingual, you were included in the analyses, but there were some dropouts along the way. So here are our participants. We're on average, one of the good things is randomization worked. It actually really balanced our demographic variables in substance use and substance use history. So no significant differences between groups. On average, individuals were 31 years old, predominantly white, 82%, 83%, 7% Black, 7% Hispanic. Mean gestational age at enrollment was around 21 weeks gestation. One of the statistics that's pretty impressive is that 98% were already receiving sublingual buprenorphine at randomization. And we can talk about that. That was a really mix of people that maybe had been on this before they got pregnant. But if you just imagine somebody who wasn't on that medication, became pregnant, came in for their initial evaluation, to get them into a randomized controlled trial is really, that's a huge stretch. So a lot of times we were stabilizing them on buprenorphine and then approaching them for the research study. So it made sense that most people had already been receiving buprenorphine at the time of, randomization. So urine drug screens, these were that were positive at the time of enrollment into the study. And I should mention the way that urine drug screens were taken, we never saw those results. They got sent centrally, so we never saw these results as part of the study. But at the time of enrollment in the study, we had high rates of cotinine, 85%, cannabis use, 17%, amphetamine and methamphetamine use, high comorbidity with our DSM diagnosis of opioid use disorder or other substance use disorders, stimulants, you can see there, cannabis as well. So sort of a really representative population. I think this is what most people are seeing in practice. I put this in here just so people are familiar with this. On the left-hand side is the sublingual dosing of buprenorphine. If you were to convert somebody to the extended release, which we did in this study, to the weekly Brexadi dose, those are sort of the conversion doses there. Over on the far right is the Brexadi monthly dose. We did not use that in pregnancy. It has an incipient that has some teratogenic effects in animal models. So people did not receive monthly Brexadi in pregnancy. But during the postpartum period, if you were assigned to the weekly Brexadi and you were not breastfeeding, you had the option to switch over to the monthly. So I just put that in there for reference. I wanted to, because I think this group prescribes a lot in pregnancy, so I wanted to just provide a little bit more detail about the medication exposure during pregnancy in both groups. So in that middle column, those are our folks with the assigned to extended release. About 59% of them were they were at 32 milligrams. So that was sort of a common dose in that group, which is equivalent to 18 to 24 sublingual buprenorphine. Obviously, they were getting that as an injectable. It was a weekly dose, and about 12% discontinued that medication during pregnancy. In the sublingual group, the mean dose was about 18 milligrams per day. We had 69% of participants that were getting buprenorphine only, which is a little bit different today, but this study took place from 2020 to 2024. A lot of people were still getting buprenorphine only. 61% or sorry, 86% were sort of splitting that dose multiple times a day, as we commonly see as people go through pregnancy, and about 9% discontinued that medication during pregnancy. So postpartum, the extended release group, 58% of people switched over to that monthly injection. They were not breastfeeding, so that was an appropriate thing for them to get. They were on average received weekly, those that stayed on the weekly injection, I should say, were the highest dose was 32 milligrams. That was sort of the most common. And then among participants receiving monthly injection, that highest dose was 128 milligrams. About 37% of people discontinued that medication postpartum, which is a little bit lower than sort of average rates, but that was the postpartum rate of discontinuation of extended release. For the sublingual group, they stayed on roughly that 18 milligrams on average through the postpartum period. 43% received only buprenorphine only in the postpartum period, which is different. And then 83% were continuing to do multiple doses per day. They're just dividing their dose throughout the day. And then about a third discontinued their medication postpartum. And we'll make these slides available too if people want them, but it's a lot of information. And this is a lot of information too, but really just want to call your attention to the main outcomes that we have here. The first outcome was in pregnancy and looking at effectiveness, and that, oops. I did highlight that. Yes. So the main outcome here was that during pregnancy, the extended release group had more opioid negative urines in comparison to the sublingual group, a difference of almost 10 on average 10% difference. And we also had some differences in terms of adequacy of prenatal care. So you can see the sublingual group probably had more adequate prenatal care than the extended release group. So this is postpartum. There were no differences across the board in terms of the illicit opioid negative urines. They were the same buprenorphine adherence, drug and alcohol abstinence, opioid craving. There was a small difference in the short opioid withdrawal scale. So those with extended release had lower reported fewer symptoms of withdrawal. Not a huge amount different, but nonetheless, that was significantly different. In terms of our safety outcomes, sorry, I'm just going to move this around. Our safety outcomes, the only thing that, again, there was like basically looking at the receipt of opioid pain management medication. The extended release group got less of that overall in terms of just receipt of that and medication, and then the sublingual group. And then they also had slightly lower anxiety scores in comparison to sublingual. So this is just to summarize again, that was a big long table, but just to look at our primary outcome of illicit opioid abstinence during pregnancy. Extended release had more opioid negative urines in comparison to sublingual, and then postpartum, there was really no difference. So this is looking at some of the safety outcomes for the newborn. You can look across the board at the different things that were sort of the key secondary outcomes in terms of NOWs and receiving treatment for NOWs and length of stay. Things that we are interested in like child custody, child protective services being involved, and developmental issues. And we'll talk about that in a second. But the only difference that was found here was a slight difference in head circumference, with extended release having sort of 0.6 centimeters greater head circumference than the sublingual group. So overall, secondary outcomes in terms of infant outcomes, really no differences in our NOWs outcomes that we were looking at, our need for treatment. I basically said all this, but the developmental outcome in that table is a little, it's not misleading, but basically just to highlight, that was a screening for, it's the ages and stages developmental screening. So just screening for developmental problems. It wasn't like a Bailey's test or something more in depth like that. It was just saying that there was no differences in screenings for the developmental outcomes at that time. This is looking at adverse events, and I'm just going to summarize here because it's a little bit easier. Serious maternal adverse events were less common with the extended release group, and actually quite a bit during pregnancy. Extended release was about 8%, sublingual was 26%. Postpartum serious adverse events, again, extended release fewer, about 6% versus sublingual. But the in terms of like medication related non-serious adverse events, that was more common in the extended release group. But those were mostly mild to moderate. And a lot of those were just sort of injection site irritation. We looked at those injection sites every single week. We would describe them in great detail, where they were a little bit of red, indurated, like that everything got reported on that. And so they were, not surprising, had more of those. Um, and injection site things were pretty mild. We didn't see major problems with that. So overall, I'd say, the amazing part about this study is having a randomized controlled trial of opioid use disorder in pregnancy, comparing two different medications. That's really awesome, and sort of multi-site across the country. Really high treatment and retention rates. If you think about this population coming in every week during pregnancy, every week for 12 months postpartum, is quite a feat, and it was really, really wonderful retention. And pretty comprehensive in terms of maternal and infant follow-up and assessment. Limitations, as you saw, the sample is still relatively small. It's largely white, and people were clinically stable when they got enrolled. We had a lot of people that probably were making their way into treatment and never made it into treatment and never made it into the study. So it is a pretty clinically stable population. It's an open label design. Some infant outcomes may have been underpowered. And as I mentioned before, most participants were on buprenorphine at enrollment, but that doesn't mean that they were on it forever. It could have been relatively recently that they got started. So overall, what we see here is weekly extended release buprenorphine improved illicit opioid abstinence during pregnancy. No difference in terms of abstinence in the postpartum period. Infant outcomes, including NOWs, relatively similar between groups. Extended release was associated with fewer serious adverse maternal events. And then I think overall, this sort of study makes us feel comfortable using this as a potential option for the treatment of opioid use disorder in pregnancy. So I will go ahead and stop sharing. I think that's all I had put together.
Awesome. Thank you so much, Connie. So
Sure.
please feel free to put questions in the chat, and we will have we knew people would have questions given kind of the press that this new study has been getting. So we have some space for that now. So the first question that came into the chat was a question about some of the methods for your secondary infant outcomes. I know you mentioned the ages and stages questionnaire, but there was one question about collecting data on the Child Protective Services, custody, those types of data points. So do you have any feedback on how that data was collected across the sites?
Yeah, and so as you know, I mean, states different, hospital systems within states differ in terms of reporting requirements. So there was a pretty diverse group of people, sites and states that had different reporting requirements. And it was just something that we thought was an important outcome to have a pulse on to see, particularly to be sure that being in that study did not increase that happening for that site. So as a site, we wanted to sort of have a barometer of that as well. I think it was just put in there because it's an important outcome to be looking at.
And I had a question. So just on their last slide about the serious adverse events between the two groups, I just wanted if you can just comment generally what those serious events were and just in general, like your general gist.
Yeah. So our institutional review boards define, I think it's actually even it's a federal definition of a serious adverse event. And so that means that person got hospitalized outside of pregnancy for the study. So there was something severe enough to require a hospitalization. It could be a life-threatening event. It could be something that is, medically or psychiatrically an instability that is very severe that occurred during this time. It could include death, congenital anomalies, that didn't happen in the study, but those are what are considered serious adverse events and have to be monitored throughout the study. So, what we can really only speculate, like why the extended release had more of that. Sorry, extended release had less of that. But I do wonder, if you are, extended release had fewer adverse events, they had more abstinence, which makes me think that they were maybe using less, and therefore there was less complications and problems happening. That is potentially one explanation, but we don't really know.
And a follow-up question that came in the chat related to that was about the not serious, the mild and moderate events that differed between the two groups.
Yeah.
Generally, other than the injection site reactions, was there anything else that popped up as kind of having a pattern at all?
No, and that was the main driver of it was the injection site reactions.
I can imagine. A question came up about saying how were missed doses handled, I guess both clinically in the protocol as well as in the statistical analysis.
Yeah, so I can speak to the one of the things that happened quite a bit is that if somebody if they were in the injection group and they were having craving or withdrawal, or they missed a dose, or you needed to bridge them to their next injection, we used sublingual buprenorphine, and so that was at least for our site, that was a common practice. In the analyses, that's not mentioned in the analyses, and I'm not sure how or why they, account for that, didn't account for that, but the injection group was able to get sublingual buprenorphine.
Did that happen a lot at your site? Was people, I feel like weekly injections, I think the first thing we just think of, like I have no one on weekly in my clinical practice, and that's just me. Most people want monthly. So I was just thinking like the burden of it and just trying to see clinically, did you see that a lot, at least at your site?
Yeah. So I also can sort of speak to the time. So this was 2020. It was when the pandemic hit, and we had to figure out how to do the study. And so a lot, I don't know how many sites did this, but I think it was at least half, where we actually went out to the participant. So particularly in our state, because it's very small, to be able to get the recruitment numbers, we needed to recruit from across our state, and we needed to make sure people got their injection and we got the study data that we needed. So we actually went to participants. So I'm curious how this is going to look in clinical practice, for people having to come in. But the good news is if you do injection and the person doesn't come in, you can always just then prescribe the sublingual too.
Yeah, and a follow-up question to that you just brought up, such a unique aspect to the protocol is being able to go to where people are. I just feel like we're always in these silos and we make all the patients and participants always come to us, and we talk about meeting people where they are, but I love that you actually incorporated that in real life, meeting people where they are for this study. So there was a question that came up about kind of what exactly was happening at those weekly study visits. Was there any therapeutic non-pharmacological therapeutic intervention happening, or was it just research study assessments? If you could comment a little bit more on those weekly check-ins.
Yeah, the weekly check-ins were really sort of a brief medication management visit, and then also a study visit. So collecting urine, doing some rating scales, drug accountability, those sorts of things. But so they did not provide any other additional supports or therapy in that session, but people were able to get any other therapy that they wanted to. So I know that some sites people were in more IOP type settings, intensive outpatient programs. We had people that there wasn't anything additional. There are some people that were in weekly therapy. So it was really whatever supports that they wanted and could get, they would do that.
If anyone else has questions, please put them in the chat, or you could also raise your hand. We have space for that now. A question I just had that was just generally, what was some of the verbal feedback that patients gave you when they were coming into the site and getting the weekly injection? Was there anything that kind of, I know there wasn't any qualitative data in the paper, but you can probably anecdotally talk about what qualitatively patients told you about things that they liked or disliked, or facilitators or barriers also to staying in the study that we should all think about going forward for other research studies or considering this in our clinical practice.
Yeah, that's a great question. And I should mention too, there were two sort of ancillary studies to this study, and one of them was actually about recruitment into research studies for people with perinatal or just substance use disorders. And so there's some good key findings in that. From a clinical perspective, so and I wish our medical clinicians were on the call because they were seeing these individuals weekly and had some really good insights. One of them was that for the injection, we really, at the end of the week when they were getting ready for their injection, 2 days before, there was frequently a need to bridge. And when somebody is just even anticipating that, it also changes the dynamic a little bit. So it was pretty routine that we just allowed people to have that on hand the weekend before. Um, I think that what people really liked and why they continued the weekly visits was just the relationship with the team. Like, I don't think that there's anything more special here than just like really good rapport, trust, and support. And that's why I think people were willing to continue to do the study with us and engage in care.
That's a great comment. I think that's really important for us who are doing research with this patient population is a lot of times it's the intangibles that can go a lot farther, sometimes in helping support this population being included in research studies that historically has been quite excluded.
Yeah.
As a follow-up to that comment, there was a question about the supports that were provided outside the medication and maybe how that differed between sites. Maybe you heard about that in some of your site calls. That probably fed in a little bit into what you're saying, that relationship with the team. If there's any examples of tangible things that that was provided or linkages provided by the study team, that would be good to know.
Yeah. So I feel like in clinical care, we do not bend over backwards enough to accommodate people's crazy schedules and lives. In the research study, we did. Like there was motivation on both sides to make that happen. And whether that is solving for transportation or meeting somebody at an odd hour or allowing them to miss several appointments and still be there for them. Like I feel like in the research study, we did that more than what people tolerate in clinical care.
Yes, and I think all that comes down to structures of our systems and funding a lot of
Yep.
times that restricts things or expands things if you want to be more strength-based in that statement.
Yeah, absolutely. Yes.
Oh,
That's
I see a physical hand. Go for it.
Never can figure out how to other hand, the electronic one. So, um, I mean, great study, and I love this discussion about being flexible. Uh, we do that a lot, and I work inside of a high risk OB clinic, and we do a lot of finding people going over to the hospital that's attached to us to find them, and we do get some backlash for that. So it's really good to just hear you saying that that's part of what made this study successful. Can you talk about how like doing this study has changed your practice? Like having gone through this study, like not necessarily the connection part, because I am so into that, but like the practicality, like are you doing more injectables? Are you doing weeklies? Are you doing like what has how does this impacted your decision making as a person who, was part of the study?
yeah. And for us, so injectables are a really difficult thing to cover through insurance in our state. And that is the biggest barrier to implementing this at this point. So it has not been routinely been like, hey, this is on the table as an option for you. But I think what the biggest lesson learned, and I think what we did before, but we do even more so now, is how accommodating and flexible and how we just recognize like addiction is about ambivalence and there's a moment of opportunity. And if someone shows up at that time, like you're going to try to meet their need. And that's not always realistic for physicians and PAs and nurse practitioners. And so we have sort of built into our system and like grant funded our care coordinators, that the people that are, going to continue to pursue to outreach and sort of make the logistics of that connection happen between the patient and the provider. And it's like, I can't imagine doing this work without that. Like it just is, it's what has to happen because as you're saying, Caitlin, like the system doesn't really support what's needed to get this group engaged in care.
I have a question about the weekly versus the monthly injections, and I know this is probably going to keep coming up. I know when the trial started versus now about the change, we've had some more data on, the monthly injections, both Sublocade and Brixadi. We've had on the Journal Club before, Mel Ramage, who presented on, kind of like a case series, bringing together observational data, at least on the monthly Sublocade. And so I was just curious, like for you, as someone who worked on this trial and saw these patients and also are working clinically, if your take on offering the monthly injection to our pregnant and breastfeeding patients, and any insight that you have from the study team on how we can extrapolate these findings into the clinical practice today.
Yeah, that's a great question. And I've seen that case series. And I think that if somebody is on a medication and that is the best medication for them, right? So if somebody is on that monthly injectable and they get pregnant and they are on that because they couldn't tolerate the weekly injectable, they couldn't tolerate the sublingual, then you're going to take the risk of the monthly injectable, which is it's based on case series. Like I can't really tell you what the true risk is at this point, but we know that there's potentially some risk that we are trying to figure out what that is. And if that patient understands that and you have that sort of shared decision-making conversation, then great, go ahead and use that because the alternative is that they're not going to be on something. But if there is, I think it just goes back to that risk conversation of going through like, what are the different options at this point? What do we know about them? What do we know about you and what's best for you? And then coming up with the one that is the most beneficial, the least risky. And so I wouldn't jump to the practice of like, let's just put everyone on monthly. It's great. It's really an individual thing at that point. And I don't feel um I don't feel confident or relieved based on case series data. Like we know we need 500 exposures to a drug and plus more actually to qualify given all the things we have to control for to determine whether there is a risk for a malformation, right? Like it's just not, we're not there yet. And I wouldn't be able to say that confidently.
Yes, all the more reason why I just want to applaud the team who worked on this study. Like being able to do a clinical trial in pregnancy, let alone medications for OUD, is a huge feat, to be able to get a study of this level of evidence completed, to be able to move the field forward. So we're all very thankful for that. Does anyone have any remaining questions for Dr. Gill today? Well, I put in the chat the save the date for our next journal club, which is going to be June 30th at 3:30. I believe Dr. Dennis Ham will be speaking about methadone split dosing, and kind of contemporary data on that. So that invite will be coming, so please save the date. But I just wanted to say thank you, Connie, so much for coming. We really appreciate you taking the time to present to us. This journal club was recorded and it will be posted on my lab's YouTube station, which I also put in the chat already, and that email will be going out also soonish this week too, to share with others who are in your spaces. Thank you everyone so much, and I hope you have a wonderful week.
Thanks for having me. Thanks, everyone.